The current scenario in ART training across the world is of observation only, which although gives you a fair idea of how the procedure is being done, but does not give you the confidence of performing it independently.
I just finished a visit to Indira IVF Group in Udaipur, India, and I'm totally impressed by several things. But one of the things that I'm most impressed of is the way they just prepare themselves for the future and how they're expanding.
I'm here this afternoon visiting the Indira IVF Center in Udaipur. It has one of the most cutting-edge facilities that I have seen, including the perfect training for physicians and for embryologists. And I really think this is the future of how to train superb doctors and superb embryologists.
Embryology is confined not only to collection of gametes or making embryos, but it is about making euploid embryos to achieve a higher pregnancy rates. Embryology skills, lab culture conditions, gamete handling, and optimal environment are desired and necessary to achieve such results.
So, hi, Thomas, and formally welcome to you. And just to brief you a bit about IFA. So, IFA is an academic wing of Indira IVF Hospital Private Limited. And at IFA, we are committed to training embryologists as well as clinicians. So, we have both long-term as well as short-term courses. We have specialized courses like for ICSI, for cryopreservation, for biopsy, for all the procedures, embryology and all that. And we not only train our embryologists, but we have now opened our gates to for all the doctors and aspirant embryologists whosoever wants to be a part of this ART technology, and they can just come here and learn the techniques, have their expertise as per Indira IVF protocols.
Super.
So now coming back to today's topic. So today we are really all set, ready to listen to none other than Thomas Freour, and he's an expert. He has special interest in stem cells, and just a minute. So he has a special interest in stem cell technology. Okay, so somehow. And today he'll be talking on ultra-fast warming protocols. And without wasting any time, I would directly like to go to Thomas. And yes, so Thomas, he's the professor and he's an embryologist and head of the ART department at University Hospital of Nantes, France. And he's a coordinator of the research, development, and innovation program of the biology section of the reproductive medicine services of the Dexus Clinic. And he has over 200 publications. That's an exciting thing, that he has more than 200 publications in embryology, gynecology, andrology, and developmental biology. And as I told you, he has special interest in stem cell and development and fertility research. So coming directly to you, over to you, Thomas.
Thank you. Thank you very much for the introduction. Hello, everybody. I'm extremely happy to be with you today. I hope that the connection is good, and I will now share my screen. As I said, I'm extremely happy to be sharing with you today my experience with the fast warming protocol for embryos, and I will also tell you a few words about fast warming for oocytes and fast vitrification. So just before I start, I'd like to state that I am the head of the IVF department of the University Hospital of Nantes in France. I'm also an editor for the Human Reproduction Journal, which you might be familiar with, I guess. And finally, I'm a scientific advisor for a VitroLife company. So just a little bit of context. For sure, you are aware of that, but the IVF activity is increasing worldwide at the moment. It is generally reported that infertility issues affect more or less 15% of couples, and I could see that this means more or less 28 million couples facing fertility issues in India. And actually, there are more or less 2 million IVF treatments annually in the world, among which 300,000 IVF treatments are performed in India every year, which is, of course, a huge number, more or less equivalent to what is performed in the US every year. And from a business point of view, the expected market is $40 billion US in 2030, within 5 years, with an annual growth rate of 5 to 10%. If we get back in the past of IVF, most probably vitrification would be considered the latest revolution in the field of IVF, because it significantly improved oocyte and embryo survival rate and clinical outcome as compared to slow freezing, but also it allowed the full integration of freezing and segmented strategy into IVF care. And finally, I don't know if some gynecologists, some clinicians are connected today, but the prevalence of freezal strategy for various indications is increasing a lot, not only for ovarian hyperstimulation, but also for premature progesterone elevation, for trophectoderm biopsy, fertility preservation, etc., etc. From a technical point of view, vitrification, oocyte and embryo vitrification, and warming procedures, they are based on progressive exposition to increasing for vitrification and decreasing for warming concentrations of cryoprotectant. And the overall duration of the procedure is generally between 15 to 25, 30 minutes per embryo. And that means that it can be really time consuming in the lab. Many people tried to find some solutions to lower the duration of this technical procedure, but at the moment, there was not really a clear benefit from these new strategies, especially from considering the automated systems, which did not prove beneficial in terms of organization. So we had this increase in IVF activity, this increase in fertility preservation, this increase in freezer strategy. That means a lot of time for oocyte and embryo vitrification, and also for oocyte and embryo warming. And that, in the end, means a heavy workload, a lot of time for the IVF staff in the lab. Very difficult. So as I said, many people tried over the last years to reduce the workload associated with vitrification and warming. The first approach was automation. There were several attempts to develop automated devices for vitrification or warming. And you have some examples of papers here, and also an automated system available on the market. There were many promising articles and communications, but although the clinical outcomes were satisfying, the reduction in technical time for the procedure was not really demonstrated. So we are at the very early steps of automation. There is almost no clinical validation in humans at the moment, mostly in mouse oocytes and embryos. And the only commercial device that is available on the market, it did not prove to be efficient for the reduction of the workload in the lab. So this was an overall introduction and context. Now I will focus my talk on my experience on fast warming of human blastocysts. Just to tell you where I am working, so I'm working at the University Hospital of Nantes, France. It's, let's say, a middle-sized IVF unit for France and Europe, because we perform more or less 1,300 ovum pickups per year, and we do IVF and ICSI. We have a PGT program, egg donation, and fertility preservation. And the most interesting, let's say, evolution in our activity over the last years was the very rapid increase in the number of frozen embryo transfer cycles. And we almost doubled this number over the last 5 years. And now we perform 1,300, even 1,400 frozen embryo transfer cycles per year. We perform blast culture for every patient without any exception, 100% blastocyst culture program. We perform more than 95% of single blastocyst transfers. All the embryos are cultured in time-lapse systems because we have embryoscopes in the lab. And here is a picture of the staff. The indications of blastocyst freezing that we have in our setting, just like everywhere else, I guess, for supernumerary embryos, for freeze-all cycles, trophectoderm biopsy, and fertility preservation. Embryo quality assessment is made on day 5 or day 6 with Gardner classification. And in addition to Gardner classification, we use the algorithms proposed by the time-lapse systems, the embryoscopes, which are KIT score and IDS score to rank the embryos in the cohort. And finally, the medium we use for vitrification and warming are the one from Vitrolife, VitBlast and WarmBlast media. And here is an overview of our activity. And as you can see, except let's say the modification in the COVID period, we had the overall activity multiplied by 3 in 10 years, not only for blastocyst culture, but for blastocyst freezing and warming. So what was the objective of the study I will present you now, just before we decided to implement the new ultrafast warming protocol? The question was, is it possible to reduce the staff's burden and optimize lab's workflow by shortening the duration of blastocyst warming protocol while maintaining stable clinical outcomes? So this was the idea, to lower the workload and keep similar clinical outcomes. So how did we do that? Let me present you now the ultrafast warming protocol as compared to the conventional blastocyst warming protocol. So conventional blastocyst warming protocol is this one. We have first step, warm 1 at 37 degrees for 2 minutes. Then second step, warm 2 for 3 minutes. And then third step, warm 3 for 5 to 10 minutes. And usually we use 10 minutes. And then we move to culture medium before embryo transfer. So the overall duration of this conventional warming protocol is 15 minutes. And now here is the new ultrafast warming protocol. And the ultrafast warming protocol is this one. You have exactly the same first step, warm 1 for 2 minutes. And then you skip the second and the third steps, and you move directly the embryo to the culture medium. So the overall duration of the new ultrafast protocol is only 2 minutes. Where did this idea come from? We heard we could see some preliminary results during congresses in 2021 and 2022, mostly from Belgium. And these people, they showed no significant difference in embryo survival after ultrafast warming as compared to standard warming protocol. So this was quite intriguing for us to see that these embryos with the ultrafast protocol, they had the same survival rate, but this was very preliminary and it was not enough. It has to be continued with further clinical studies. So we decided to move things forward and to develop and implement this new protocol in our setting, but after clinical validation. So the first step of our clinical validation was basic research experiments on embryos donated for research. And then we did a clinical pilot study. And finally, we implemented the new ultrafast protocol in routine practice in 2022. So it's now more than 2 years that we are using this new ultrafast protocol. So let me share with you briefly this clinical validation. So the first step in May 2022 was basic research experiment. and we tested this ultrafast protocol, ultrafast warming protocol, for blastocysts donated for research. And we had 27 blastocysts, and survival was excellent, 100%, and expansion rate was also, as usual, more than 80%. And in this research program, we study several markers of embryo development, as you can see in the picture here. And this is something we had a lot of experience with that. And we tested the same markers that we used before with the conventional protocol, and we could see that the staining, the expression of these markers was perfectly conserved, maintained with the new ultrafast protocol. So this confirmed that the embryos not only survived, but also that their, let's say, development, their constitution in terms of cellular fate was conserved. Then, after this first step, we moved to a pseudo-randomized pilot clinical study in July 2022, and we decided to allocate patients for frozen blastocyst transfers to either ultrafast or conventional warming protocol on a weekly basis. So that means that 1 week was devoted to conventional protocol, and the week after we shifted to the ultrafast protocol, and then etc. during 1 month. And as you can see here, the results were perfectly stable and comparable between both groups, because embryo survival were 100%, expansion was comparable, or approximately 80%, and clinical pregnancy rate and live birth rate were comparable in both groups also. So now here are our current results after more than 2 years of using clinically this ultrafast warming protocol. First, we have a paper accepted for publication in Reproductive Sciences journal. The title is Ultrafast Warming Procedure of Vitrified Blastocysts Results in Maintained Embryology and Clinical Outcomes. And the main results are the following ones: survival, expansion, and clinical outcome are strictly comparable. We have now more than 2,500 warmed embryos, more than 98% survival rate, and the live birth rate is somewhere between 28 and 29, which is our, let's say, average result in our clinical program. So here is the table that is presented in the paper. I will not go into detail, but as you can see, we had a 6-month period, a study with the conventional protocol on the group 1, and let's say a 3-4 month study period in the group 2 with the ultrafast warming protocol, and more than 300 embryos here. And you have all the numbers, as you can see, and the p-value is not significant for any variable, any outcome. So this is our experience now after 2 years. We would never go back into the conventional protocol because it works perfectly with the new ultrafast protocol. And I will share with you later in my speech, in my talk, that the staff is very happy, not only with the results, but also with the time saving of this new protocol. What is available in the literature, because we are not the only ones in the world using this ultrafast warming protocol, of course. And I encourage you to read the papers from Jürgen Lieberman from Chicago. And he's an expert in the field. He presented his data at Freour in the VitroLife studio along with me, but he also published quite a bunch of papers. The latest one in 2024, just a few months ago, more than 800 frozen embryo transfer cycles versus 2,000 with the standard multi-step protocol for blastocysts. And the primary outcome was ongoing pregnancy rate. And here are the results. Everything is extremely comparable. The only thing is that he could demonstrate, he could report that after adjusting on age, PGT, blastocyst development, and expansion, that the ongoing pregnancy rate was even not comparable with the standard protocol, but it was even improved, which we didn't have in our experience. So this is very, very good data, very good study, and it confirms our findings. Another paper here from the US in 2024, it's kind of a pilot study on 200 blastocysts, and also you can see that the survival and the expansion rates were absolutely comparable between both groups. And it was not only about survival and expansion, but also they had a clinical study, and the outcomes were once again perfectly comparable between both groups in terms of live birth rate, implantation, clinical pregnancy rate. So once again, in the US, in Chicago, in Boston, and our results, standard protocol and ultra-fast warming protocols, they work perfectly the same. Just a few words about fast vitrification, because it's also very time consuming. The ultra-fast vitrification protocol with shorter or even no equilibration steps were published back in 2019. It was in mouse oocyte at that moment. And the authors of these papers, they reported similar or even improved outcomes in mouse oocytes when they used this shorter vitrification protocol. Once again, Jürgen Lieberman from Chicago, he tested in human immature oocytes by a direct exposure of these immature oocytes to vitrification solution. And he found that the survival and development of immature oocytes were consistent after ultrafast vitrification. So this is once again reassuring and encouraging for the future, that we can not only simplify and shorten the warming procedure, but most probably we will be able to do the same with the vitrification procedure in the not too far future. And here is a last example of a communication that was made this year at ESHRE in Amsterdam by a famous group in Spain, in Barcelona, called Embryo Tools. And once again, with the same protocol, the same principle of this study, that fast vitrification and fast warming protocols, they demonstrate similar efficiencies as compared to the conventional protocols. So before I end up with this talk, I would just like to share with you a few comments and perspectives. The first, and maybe the most important in my opinion, is that this fast warming protocol, and probably in the future a fast vitrification protocol, they lead to, let's say, comparable outcomes. So you will not gain, as far as I can see in the literature and in my experience, you will not gain extra pregnancies with these new protocols, but you will be able to save a lot of time for your activity in the lab. And this is a matter of satisfaction of the staff. My colleagues, myself, we are very happy with the new protocols because it helps us save a lot of time in our daily activity. So the workflow is better, and that means that we feel better. We can schedule more activity if we need to. This is actually what we did with more frozen embryo transfers per day. And we also can have more flexibility in our organization and daily schedule of the lab. So this is more comfortable in any aspects. Just like the same for time-lapse imaging. If you are familiar with the time-lapse used in the IVF lab, it's not clear if you will gain some more pregnancies, but you will gain a lot of time and comfort because you gain more flexibility. Of course, it's very important that the outcomes are maintained, which is the case, and it has been confirmed by many more and more teams in the world, including ours. And the data on ultra-fast vitrification are encouraging, although this needs further confirmation. And interestingly, when I began working in the field of fast warming and fast vitrification a few years ago, I was very surprised, and after discussing with people at Ultralife also, I was very surprised to realize, to discover that these new protocols, well, actually, they are not really new. Why am I saying that? Because no less than 30 years ago, in the early 90s, there were some publications available in mouse animals. Here was a bovine blastocyst, reporting exactly the same numbers and the same results. So this is quite intriguing, and maybe we should be upset about that. I don't know, but maybe we lost 20 or 25 years using these very long warming protocols, while some data were already available 30 years ago that we could do ultra-fast warming protocol. Of course, it was not human, it was bovine blastocyst, but we had everything under our eyes in the literature back in the past. So this is just a general comment that before, let's say, considering any kind of revolution, new protocol, innovation, maybe we should, let's say, be humble and look at what was done before by pioneers and colleagues, especially in animal models, because maybe the answer is already available. So we should take inspiration from animal models and learn from the past. This is my opinion. Maybe you would disagree, but I think it's very important. So now I will move to the conclusion. Blastocyst vitrification and warming, it's an activity that is rapidly increasing, and it's associated in every IVF labs in the world with heavy workload. And maybe I would say that given that you have in the DRA group a very nice training facility, maybe it's something that is many people want to train about vitrification and warming. It's something that is you have to train. It's not that easy to perform well vitrification and warming. Well, with these new ultra-fast warming protocol and ultra-fast vitrification protocols, maybe training will be better and easier in the future. The ultra-fast warming protocol, it brings excellent and consistent clinical results in my setting, in my experience, but not only in my setting, also in other places in the world, including the US. And it allows optimization of flexibility and workflow, and altogether, good clinical results and better flexibility and workflow. This means better comfort for the staff and better quality for the lab, which is, of course, a priority for all the embryologists. And ultrafast vitrification is still under investigation, but most likely in the not too far future, it will provide the same positive conclusion. And altogether, just to conclude once again, I think that we are at the very beginning of a new era in the field of IVF and in the field of cryobiology, because all these new data, it's a kind of shift in paradigm, and it sets the basis for improved cryo program with shorter and standardized procedure, which maybe in the next years, we will do more and more freezing, more and more warming, but with more and more simple and short protocols. And maybe this would lead to a complete reorganization of the IVF activity in the lab. And with this, I'm done. I hope this raised your attention. I would be very, very happy to share with you, to discuss, and to get your comments and questions. Thank you very much.
Yeah, thank you. Thank you, Thomas. That was really a very short, crisp, and eye-opening seminar I think I would have ever seen, because why I would say why it was an eye-opener, because so many embryologists, including me, and I think most of us might be very fascinated to know that, yes, we can reduce the time so drastically with this ultra-fast rapid warming technique.
Yeah, you can, and now we have more and more confirmation that you can reduce the time. So it's better. It's not a difference for the clinical outcome, and it's better for the staff. It's better for the patients. Better for the organization. So I mean, this is very important. In DRA group, you have so many labs, so many staff. I think everybody is very busy every day, just like in my lab and every lab in the world. So just to let you know, for example, in my lab, we save every day 1 hour and a half for one embryologist. 1 hour and a half. It's 1 hour and a half is a lot. It's very, very significant.
Right, and obviously for the labs with high work volume, it is really a boom for those labs where
exactly
There
Exactly.
are so many thawings per day. And can you just elaborate a bit about that? What is the principle behind this? Like, see, for normal conventional warming technique, we understand that it has to do with the molarity. What we have been taught for the year, for ages, we have been taught this, that it's the molarity that gradually increase the molarity, and then you do the vitrification and the thawing part. So how it is working this way?
But that's a very good comment. I don't have let's say, the molecular data on osmolarity, but most probably the change in osmolarity is at the very beginning of the embryo warming. And then it was some kind of concern about the safety and embryo survival that we used decreasing cryoprotecting agent solutions. But most probably everything is done in terms of osmolarity change within the first 30 seconds. And just for your information, there were some very early reports that you can even warm human embryos directly in culture medium without using warming medium. So this is something that needs confirmation. I don't have this experience, but I heard and I could see some reports that some people now, they warm embryos directly in culture medium. So it's not a recommendation. I'm not saying that you should test it, but just to illustrate that most probably the embryos, they can resist very brutal change in osmolarity. I don't know why in the past we are very afraid of this change in osmolarity, but apparently the embryo, it can survive something very, very immediate, very brutal.
Okay, right. So
we do have a lot of questions. I think the topic is so new and exciting to everyone that we do have a lot of questions actually popping up in the chat box.
Yes.
Some of them are connected.
I will try to answer them. So can I use the current TS for the same protocol, or the composition for rapid warming is different? Okay, so I don't know what this person is referring to. My experience is with Vitrolife warming medium. Okay, so I cannot comment on Kitazato or Fujifilm and other warming media, but if you look at Jürgen Lieberman publication, it's with Fujifilm. I think it's with Fujifilm, the warming medium. So I guess this is something that is possible. The ultrafast warming protocol is with commercial warming media. It's not a different medium. It's commercial media. Okay. So to answer the question, the composition is not different.
Okay.
Can I know about the percentage of cryoprotectant present in rapid warming solution? So yes. So for Vitrolife warming medium, it's either Warm Blast 1 or Omni 2. And if I remember well, is 0.5 molar sucrose. 0.5 molar sucrose.
Okay. And so otherwise they can check with the whatever the vendor is providing the media, and if it is 0.5 molars, then it is okay to go with that media. At least to do, I would recommend that at least to do a pilot study, at least check with some extra embryos. You can check with them whether what was the survival and competency of those embryos.
Of course, it's better to perform a validation with abnormal embryos or aneuploid embryos or whatever.
Right.
But if you look now at the literature, you have some information. And Vitrolife, they released the ultrafast warming medium in the US. So maybe it will come in India in the not too far future. I don't know. You should check with Robbie. And also, I could see that Fujifilm, or Kitazato, I don't know, they released the ultrafast warming protocol in Europe as well. So I think that now you will get the answer from the supplier, from the companies.
What would be a word of caution for those who might shift to Vitrolife for their thawing solution? Now, people use different freezing kits, right? Now they have frozen in maybe Kitazato, but after listening to a session, if they just use the Vitrolife for the thawing and use this ultra warming, there might be differences because different vitrification solutions
No,
has a different molar concentration. So a
no,
word
there
of
is no
caution for
problem.
those who want to shift.
No, no, there is no difference in outcome depending on the freezing medium that you use. So if you freeze with one system and you warm with another system, there is no difference. So you can, if you want to shift to warming protocol of Vitrolife, and that you freeze with a Kitzato or any other supplier, that's not a problem.
Right. So that way it is quite similar to the conventional techniques like what we have been doing. Even we use one kit for vitrification and we might change the kit for the time at the time of warming. So it's applicable like that. Okay. Okay. So we can jump on to the next question. I think that, sir, it's mentioned like warm 1 for 2 minutes. Normally we keep only for 1 minute. Okay. You want to read it? Yeah.
Well, so I'm using 2 minutes. Maybe you can try for 1 minute, but I don't have this experience. I think that 1 minute, maybe it's, I don't know. I don't have this experience.
I think, Kitzato protocol says the first step is to be done for 1 minute, actually. Here we are used to working that way.
Yeah, so Vitrolife is 2 minutes.
And even Sage kit, I think that also says
the Cryotech, the Sage,
Sage kit also has the protocol of 1 minute. So
and then the upcoming next diluted solutions.
It is 1357. It is
1351 or 1356.
Can you please tell us the composition of this ultrafast solution? So it's 0.5 molar sucrose. Oh. Can you hold on for a second? There is just somebody calling me at the door. I will be back in just 1 second. Excuse me.
Sure.
Sure. So till we have him back, I think it's exciting to have this session. And I think there are a lot of questions. So thanks for all the questions. He's back. So yes, maybe you can again start taking up the next set of questions. And that is, have you tried for oocyte warming also or only on blastocyst?
I'm sorry, so just your question was, is it only available for blastocysts or is it also available for oocytes? Is that correct?
Yeah, so have you tried using it for oocyte warming also, or you have used it only on blastocysts?
Yeah, we are using it only for blastocysts because we don't have a lot of oocyte warming cycles at the moment. So we are just waiting for some information from teams with a lot of activity because, well, we are, for example, we are using fresh egg donation cycles. We are not freezing egg donation oocytes. So that means that we don't have enough experience and we don't have enough activity in my setting to perform a good clinical study. But I think that there is some encouraging data on oocytes as well, once again from the US. So I think it's not a problem.
Right.
But I don't have this experience at the moment.
Right. So the experience right now is on embryos, and for oocytes, it's still under trial. Maybe we need to have some studies on the oocytes also. Okay. Okay. Thanks.
Exactly. Is it possible to use it for day 3 embryo towing, or is it applicable only for blastocysts? So once again, I don't have this experience because we never perform day 3 embryo towing. So I never do day 3 freezing or towing. But my guess is that it works also because there is no reason there would be different. I mean, if a blastocyst is resisting and expanding and surviving, there is no reason that it doesn't work for a day 3 embryo. But I don't have this experience because we never have day 3 embryos.
Okay, yeah, obviously, the content, the inner cell content is almost similar. I think that it will, so it will definitely have the same impact as of a blastocyst. If blastocyst can survive, so can day 3 embryo. But still, it has to be first validated and then only proceed for this thing.
Of course, but I think that the general idea is that embryos are more resistant to the change in osmolarity, just like we said at the very beginning. So I think, except for oocyte, maybe, which is quite a different cell and a different architecture, but for embryos, I don't see any reason in theory why the behavior and the resistance would be different as compared to blastocyst.
Right. So we can jump on to the next question.
Yeah.
So can you tell us the fertilization rate and blast rate after oocyte ultra-fast warming protocols?
They have never tried on oocyte.
But they have not tried.
I don't have the precise numbers, but once again, I'm doing so few oocyte forming cycles that it's not really relevant. I mean, I can share, but it's less than 100 cycles, so I don't think it's really relevant. Maybe you should just wait for a few weeks or month, and most probably during the American Congress in October, the ASRM, maybe some people, I guess some people will share some huge series, some huge data.
Okay, so already that work is on.
Yeah, in the last 2 years, 3 years, some of the more scientists have started working on this ultra-fast vitrification and thawing, because of which I think the popularity or the studies have been on increasing trend. So we believe that in the upcoming congresses, we'll get some new insights on it, oocytes also.
Sure. And I could see that you have earlier shown some paper that were on mouse blasts. So is it being worked on the human gametes and embryos as well on extensive level?
I'm sorry, I didn't get your question.
So the papers you showed in the presentation, so they were focusing on the mouse blastocyst. So
yeah, well, it depends. There depends on mouse oocytes, but for blastocysts, the papers I showed were only in humans, I guess. It's just for the fast vitrification, the most data available is in mouse at the moment.
Right. Okay. So we'll be waiting for the some more data at least to validate this thing.
Exactly.
So we can.
There is a question about epigenetic effect. That's a very good question. It's extremely difficult to look at epigenetics in embryos. It's also very difficult to make a difference between any epigenetic that would be connected to the environment, to the gametes, or to the technical procedure. So I don't have the data for sure. It will take some years before we have some data about that. And well, in my opinion, looking at the epigenetic markers in the embryos, I'm not sure this makes really sense, because so many epigenetic changes can occur and we don't know why they occur and what they are connected to in terms of embryo development and health of the baby afterwards. That I don't know. Of course, we should look at it, but maybe the most important thing is to look at the perinatal and neonatal outcomes. Just make sure that babies are doing well, and if there is something intriguing, if there is something happening, then maybe we can question the epigenetic aspects. But at the moment, I mean, I'm not sure that the science can answer this question about the epigenetic effect. I don't know if you get me, but I think that it's not only for the ultrafast protocol, it's in general. Evaluating the epigenetic aspects of an embryo, I'm not sure that technically speaking, it's very relevant, but the question is very good.
Okay. And so we had one more question in before that. So what is the expansion time for blastocyst after ultra-fast warming, or after how many hours of warming we can do the transfer?
So in our experience, well, you can do the transfer almost any time, whenever you want. In our experience, we culture the embryo during 2 hours before checking expansion, and then we wait another 1 or 2 hours before transfer. So between warming and transfer, we have 3 to 4 hours. But this is for organization issues. I mean, if you want to transfer just after 1 hour or 2 hours of culture, that's fine. But in our experience, expansion was evaluated after 2 hours, and transfer between 3 to 4 hours.
Okay, it's just like routine warming. You wait for at least 2 to 4 hours and wait for the re-expansion, and then you can decide what's the quality of the embryo, and you can go for the transfer.
Exactly.
Okay. Okay. Good. All right. So next,
any significant differences in re-expansion of embryos that were observed utilizing the ultrafast method compared to the standard warming protocol?
Okay, so this is a very good question. In our experience, we don't have the precise data because the embryos are not cultured in the time lapse after warming. Okay, so I know that many people, they use the time lapse system for following embryo expansion and development after warming. And maybe there is some difference, but in my lab, we do not use time lapse for warmed embryos. So I cannot answer precisely. We could see no significant difference after conventional culture 2 hours after warming. Expansion rate and speed was apparently the same, but I think we need some time-lapse studies to go more into details and get more insight about that. So this is once again a very, very good question. If you have the opportunity to put the warm embryos in the time-lapse, then probably you can see some differences in terms of expansion speed.
Okay, so otherwise we don't have any significant as a number,
no.
But you have, in general, you have not seen any difference in the re-expansion of embryos in both the protocols?
No, no difference.
Okay, okay, great. So moving on to the last question in the chat.
Yeah.
How does fast vitrification compare to the slow freezing? I mean, otherwise, vitrification in terms of cell survival and functionality. And what are the limitations of fast vitrification?
Well, I think that now there is really a lot of evidence that vitrification is doing so much better than slow freezing for oocyte and embryos at any stage. I mean, I've not been using slow freezing for the last 15 years, but I can comment, I can tell you that when we use slow freezing, we had very low survival, very low functionality. So I don't know if some people still use slow freezing, maybe yes. And I know that some people, let's say, especially for day 2 or day 3 embryos, they have more or less acceptable outcomes with a slow freezing. But my recommendation would be to move to vitrification because it's definitely sure that you will improve every outcome, including survival, expansion, etc., etc.
I'm not sure if it's slow freezing, but maybe the question would be with ultra-fast vitrification versus vitrification.
Conventional.
Conventional vitrification,
Okay, yeah, you mean a conventional program as compared to an ultra-fast program. Okay, so fast vitrification compared to slow vitrification, well, just like I said in my presentation, okay, I understand better, sorry. So in terms of survival and functionality, it was exactly comparable.
Okay.
Everything was really, when we look at the numbers, it's perfectly the same, very stable.
Okay.
And was laser-assisted hatching performed on the blastocyst? If yes, was it performed immediately after warming? So the answer is no. It's a question that we have tried to answer for the last years, trying to figure out if we should use laser-assisted hatching or not. At the moment, we didn't find any evidence in the literature demonstrating that there is a benefit from using laser hatching before or after warming. And I mean, it would be, let's say, it would be strange to save time with ultra-fast warming protocol and to lose time with an additional procedure like hatching, even if it's quite easy to perform, but still it's 1 or 2 minutes to perform assisted hatching. So it would be strange to gain time on one side and to lose time on the other side. So we decided not to perform assisted hatching at the moment. But if one day there is a paper, there is a something coming in the literature with a demonstration that there is an interest, a benefit in doing laser hatching, then we will. But at the moment, we don't, because we are not convinced that it's relevant. I'm not saying that it's detrimental, but just I'm curious, but I'm just not convinced that it's something that can help improve the outcomes.
Yeah,
So I'm just trying to keep, as a lab director, I'm just trying to keep the workflow as, let's say, stable and rapid and fluid, let's say, for all the staff. So we just try to keep the technical procedures to the minimum, but we are trying to do our best for these specific procedures. I don't know if it's clear for you, and I guess it's the same in your labs, of course, at Indira Group, but no extra procedure if it's not validated in the literature.
Yeah, right. The laser is still very debatable, and I think the scientific fraternity is divided into with regards to the benefits and also the cons of the LH.
Right.
Exactly.
And earlier it was emphasized that yes, there was a point I remember that even for freezing, it was recommended that you just give the laser, and that way you just get rid of all the plastic fluid immediately, and that will reduce the time. But we have practically seen that it has no much benefit.
It's still debated. I'm open to discussion. I'm open to discussion, but just waiting for the evidence.
Right.
True.
So here comes the next question. Can you explain if freezing embryos by a normal way of Kitazato or cryotech? So either it is possible to do ultra-fast thawing, or it is mandatory to do vitrification in the same way as ultra-fast thawing.
Is it possible to do ultra-fast thawing? Yes. So you can do ultra-fast warming, thawing, whatever the vitrification you use.
Okay. Yeah, that was very clear from the talk that yes, you can. The embryos are vitrified in any way, so they can be thawed by using any media, but with the ultra-fast method, they can be done.
Yeah.
The thawing
you can be flexible on that, and you can look at the publication, the paper from Jürgen Lieberman once again. And I think that in one of these publications, I don't remember which one, but in one of these publications, he's comparing two warming protocols, one from Vitrolife and the other one from Kitazato or Fujifilm, I don't remember. And you can see that the results are comparable. So I'm not saying that all the suppliers are comparable. You can choose the one you want, but it's not mandatory to have vitrification and warming with the same supplier.
Yeah, so you can use whatever way you want, but I think your word of precaution is very clear that try it maybe on discarded aneuploid embryos with the different media if you're using with your protocol. And if it shoots, then you go ahead with the using on patients, otherwise try to refrain doing the experiments.
Exactly. How does the protocol address the risk of ice crystal formation during warming? Well, we don't see ice crystal formation, of course, under the microscope, but when you have 100% embryo survival and you have good expansion and good clinical outcomes, then you can consider, I think, that there is no risk of ice crystal formation. As I said at the very beginning, I think that the embryo is much more flexible to a change in osmolarity than we thought at the beginning. So there is no extra risk of ice crystal formation during fast warming. There is no worries about that.
Yeah. So I think before we conclude, there are a couple of questions in the question and answer section as well. I could see. Just a minute, please. Yeah. So in question answer, besides embryo development competence markers, is there any data on tunnel index for those blastocysts?
Well, that's a good question. I don't have the data. We don't do tunnel index evaluation for these embryos donated for research, but maybe we should consider that in the future. What I can say is that we had a 100% survival for the embryos donated for research, and we have exactly the same expression pattern of the various compartments of blastocyst with the ultrafast protocol. So we have a nanog expression, NR2F2, SOX17, GATA6, GATA4, etc., etc. So we don't have tunnel specifically for apoptosis, I guess, but all the markers, all the aspects of embryo development were conserved. So I guess if we use tunnel, there would be no problem.
Okay.
Is there any effect? I'm sorry. Is there any effect on embryo survival after directly exposing the embryos to vitrification solution? Well, this is what was showed by Jürgen Lieberman and in various abstracts. So I guess, I think it's too early at the moment to recommend fast vitrification of oocytes and embryos. We still need more data and validation. But I guess that in the not too far future, we can expose directly embryos and oocytes to vitrification solution. I mean, probably we can skip, it can be safe to skip the equilibration step at the beginning of vitrification. You know what I mean? So first step, equilibration, I'm quite confident that you can skip it, but then concerning vitrification itself, can we use one step only or two steps? This at the moment I cannot say, but probably we can skip equilibration and move directly to vitrification solution, although it needs clinical validation.
Right.
So the final question, that is that's the repetition. That's the same question. Actually, I would also want you to answer this thing. So warm, generally it is for 1 minute as per most of the commercially available kits. What they say the first step is to be done for 1 minute. But whereas your protocol, you are using it for 2 minutes. So now they are a bit confused what to do between 1 minute or 2 minutes.
But it's because the Vitrolife warming protocol is 2 minutes for the first step. So my data and my protocol is according to manufacturer instruction. Vitrolife blastocyst warming protocol is 2 minutes for the first step.
Okay. That is 2 minutes at 37 degrees.
We are 2 minutes in the commercial, in the standard protocol, so we use 2 minutes in the ultrafast protocol.
Right. So they'll have to try with different combinations and permutations.
There might be change in concentration or.
If you use Kitazato or Fujifilm warming kits, warming protocol, then maybe you should consider using exactly the same protocol for ultrafast warming. So if they recommend 1 minute for the first step, then go for 1 minute.
Okay.
Okay, yes, sure. That's clear. Try and use the company as protocols as been as mentioned in their protocol. So I think we have answered a lot of questions. The thought itself at times can be scary. How can we remove it from thawing solution directly into media, or how can we put directly that into the vitrification solution? But what is the groundbreaking research? It comes from the scary thoughts, and that's why it is revolutionary. So thanks for bringing another beautiful concept, which might now have a lot of brainstorming amongst different embryologists to think over and ponder over what would be this come out as.
There will be a lot of research, and then they will already have opened the gates for the new researchers to do some fresh work on this thing, this technology.
Exactly.
And this will definitely bring cut down the time duration which is normally taken for thawing, and it will enhance, not only that, it will also enhance the results, optimize the results, as your data says. So
exactly. So well, thank you very much for this very nice session.
Thanks to you, Thomas. Thanks a lot for sparing your valuable time and giving us such a big insight that will definitely help us in a long way.
I hope that in the future maybe I can meet some of you in person, and maybe I will come to India one day, or maybe some of you will come to Europe, or I'm so happy to share with with people from the field, share the clinical experience. So thank you for your questions, and thank you for your interest.
Definitely, we would actually come across a path very soon, and I think you are of one of the thoughts that you should have the thought process being spread across to others. You should have cross boundaries discussions, cross boundaries projects, so that it increases the scientific pool of understanding and it benefits the community overall in a larger span. And maybe we can come across with some beautiful projects where we can share across thoughts. And I would just like to put across that that's the reason we came across with this concept of having the webinar, not only for the embryologist of Indira IVF, because we ourselves have a pool of 150 to 200 embryologists within our system. But this sessions are open to all the embryologists everywhere, whosoever wants to join in, so that such thoughts are always spread across amongst the entire community, so that everybody can get benefit out of it. So,
and these international webinars, they are taken by IFA, Indra Fertility Academy, every third Friday, and whereby eminent international speakers, they are invited. They share their thoughts, they share their knowledge, whatever they have gained over their experience, and that's how we work. And thank you. This time it was Thomas Freour from France, and hoping to see you all next third Friday.
Bye-bye. Again. Thank you very much. Bye-bye.
Thank you. Thank you, everyone.
Thank you very much.